ultrasound guidance for needle localization for procedures. So what I'm going to teach you is how to visualize a needle with ultrasound. Now, I gave or loaned a ultrasound phantom for your residency to practice this on. None of these concepts are going to make a lot of sense until you practice. So we worked with your faculty this weekend to do some of this, and we can do this with you remotely. Again, we're going to set up some sessions with you guys, so we'll practice with you and it'll make a lot more sense, but I got to give you the knowledge first. So why do we use ultrasound when we do procedures? Well, ultrasound has been shown to decrease complications, and that's really important because when we're doing something to a patient, we want to have the best accuracy we can, but also not cause them any harm. And so it doesn't really matter what procedure we look at, ultrasound decreases complications and improves accuracy. And that only makes sense because if you can see where your needle's going, then you can avoid the things that you don't want to hit and hit the things you want to hit. So it only makes sense. And so we're going to focus a little bit today on vascular access because it's easier to give you the techniques we're trying to teach you. But all of these things that I'm teaching you are applicable to every procedure you'll do, whether it's a thoracentesis or a paracentesis, a joint aspiration or a joint injection, nerve blocks, biopsies, abscess drainage, it's all the same. And we care about, conditions or complications from procedures because CMS or Medicare has decided they're not going to pay us clinicians when we cause a problem. So what is called now is called healthcare acquired conditions. We used to call it hospital-associated infections, and we still talk about that. That's collapses. That's central line associated bloodstream infections. That's what that stands for. But now they've expanded that to any undesirable condition that arises during a hospitalization. So if you didn't have a pneumothorax, and then you need a central line, and you got a pneumothorax from the central line, even though we know that's a complication from getting the subclavian central line, that's a complication, and Medicare isn't going to pay for it. So it's important to know how to use ultrasound because it decreases all of those complications, not only mechanical complications like pneumothorax, but also infections. Now we're going to use our other transducer. So before we talked about the phased array or cardiac probe, that's what we are using for the abdomen and the heart. This one, we're going to use your other transducer, which is the linear transducer. So we're going to use this linear or flat-faced transducer, and it produces this square or rectangular image. And the reason why we do that, a couple of reasons. One is the linear or flat-faced transducer is high frequency. And I didn't tell you this when we were talking about physics, but the higher the frequency, the better resolution you have. So you'll be able to see parts of superficial structures a lot better, like the parts of the artery. And you'll also be able to see your needle tip much better as it comes into this vein or artery. The bad thing about high frequency is it doesn't image very deep. This is why we can't use it on the abdomen because it doesn't go very deep. We wouldn't ever be able to see anything inside the abdomen. We'd only be able to see the abdominal wall. So the flat face or linear transducer we use for procedures because it's high frequency, so we see a lot of detail and we can see exactly where the needle is. It doesn't see deep, so we don't use it on the abdomen, but it also is flat-faced and not curved like the other one, so our needle will look straight under there. Now, the things I'm teaching you are useful for all procedures, so you have to decide whether it's a sterile procedure or not. If it's not sterile, I don't want you to use this big bottle of Aquasonic because this big bottle of Aquasonic is a fomite. It's got a lot of germs on the bottom, and they can get inside the gel, and then the gel can be contaminated. If you're just doing an abdominal ultrasound on closed skin, it doesn't matter. But if you're doing a procedure, it can matter. So I'd rather you use individual packs of ultrasound gel, and if you don't have that, you can use the Surgilube, or in our case, the Easy Lubricant Gel. That's what we have here at our hospital. That is an advantage because it's not only sterile, it's also bacteriostatic. And so it is very acceptable to use and stick your needle through that gel. So it's a fine gel to use. Now, if it's a sterile procedure like central venous access, you got to use sterile gel, then the package is sterile, as well as a maximum sterile barrier, all right, or a transducer sheath. Now, I'm not showing you all of that today, but putting that on can be a little bit of a problem, and we can work with your residency if y'all need some supplies to help learn that, because we can get some from the company and send them to you. The other thing to know about using ultrasound, if you're just doing an abdominal ultrasound, you can kind of set up however you want. It's really not good, but you're really only going to be doing it for a couple of minutes. So if your positioning is awkward, you're not really going to hurt yourself. A sonographer, on the other hand, that's doing this for 8 hours a day, if they set up wrong, they can get carpal tunnel syndrome and achy back and achy legs. So they always set up right. Us clinicians, you can kind of put it wherever you want. But if you're doing vascular access, you really need to set it up so that when you look down at your hand, you look up at the screen, down at the hand and up at the screen. You want it to be in plane. You don't want to have to be turning your head side to side, because if you do that, your needle's going to move with you as you do that, and you're going to forget where you are. The other thing to remember is that when we teach you to hold a transducer, you'll want to hold it way up high because there's a bunch of gel down here. You're like, I don't want to get my hand in all that gel. The problem is that the higher you hold the transducer up here, the less control you have of the face of the transducer. So hold your hand down low on the transducer and brace your hand that's holding the needle. This will give you a real fine motor control, which is really important. This is where people always start off wrong. They set the machine up wrong, and they turn their head side to side, and then they hold the needle at the very end and the transducer at the very end, and they're very unsuccessful. So when we work with you, make sure you're holding the transducer down low, the needle down low, bracing your hand, and the machine's in plane. Now, there are two ways of looking at a vessel. Cross-section, where the vessel or pipe looks like a circle, and long axis, where it looks like parallel lines. Now, we're going to look at the vessel in both ways, but no matter how we're going to look at it, we always start off cross-section or transverse. The reason why we do this is, think about it like a CT scan. If you get a CT scan, that's a transverse cut across the abdomen. That's usually how you start off. And so think about if you're looking at the aorta, you would always see the aorta. So in cross-section, you always see your target. It always looks like a circle. Now, the caveat to that is you have to move from slice to slice to slice. You have to move up and down the circle to make that 3D mental image of what the artery or vein is doing in the tissue. Just like if you were looking at the aorta, if you were on slice 28, you'd have to go to slice 29 to see the next part of the aorta, and then 30, and then 31, and 32, and 33. And if you don't go to the next slice, the picture doesn't change. Now in long axis or longitudinal, we're parallel to the vein. And when we're parallel to the vein, it looks like bright lines. But just like if you were doing a sagittal view of the aorta, if you were off on one side or the other, you don't see it. So we never start off this way, because when we might miss the target we're interested in. So we always start off parallel. We always start off cross section and then turn parallel. Okay. So again, we always start off transverse. We always see our target. In this case, this is the carotid artery and the internal jugular vein. We always see the internal jugular vein. The other reason we start off transverse is that we can take the transducer and we can push down on our target. We push down. When we do that, we compress the tissues. And veins, because they're low pressure, they collapse very easily with pressure. And so we can identify what structures we're looking at. Remember, I told you that veins and arteries, they're filled with fluid, and we can't tell what the fluid is just by looking at it. We can tell what the fluid is by knowing the pressure of the fluid. So when we press down on a vein, veins collapse very easily, like this one. So that's a vein. It collapses very easily. Arteries will collapse if you push hard enough, but you'd have to see the diastolic pressure, and then it would pop open in systole. So you'd have to exceed both systolic and diastolic pressure like a tourniquet to make it collapse, and that's a lot of force. And then nerves, which are right here, they look like little grape clusters, they won't compress no matter how hard you push. Okay? Now, if you're doing venous vascular access, all right, we're going to talk about veins for a little bit, then we're going to talk about thoracentesis and paracentesis. If you're going to do venous vascular access, you never want to stick something that doesn't compress easily. So this is the superficial and deep femoral artery. This is the common femoral vein and the saphenous vein. And you can see we're pushing so hard, we're compressing the arteries, but the vein is not collapsing. That means that there's something in this vein. In this case, this is a DVT, or a deep venous thrombosis. So you wouldn't want to use that for vascular access. Now, we're going to talk about visualizing a needle. Now, if you're visualizing a needle, there's many ways you can do this. We're really going to talk about 3 ways. Really, we're talking about 2 ways. One where we look at the needle in long axis, or it's like a line. And another way, which is cross-section or out of plane or short axis. It's got a lot of names. But just think of it as cross-section. We look at the needle in cross-section. A needle in cross-section would just look like a dot. And then we're going to talk about a method where we can use them both. We can use a little bit of both. All right? Both long axis and short axis. Hopefully this is not confusing to you. So let's go through a few examples. When you practice, this will become a lot easier. So this is that ultrasound phantom that I loaned your residency. It's just a blue block that you can image. And it looks kind of gray, like soft tissue. And it has tubes in it. Now the tubes are not arteries or veins, they're just tubes. So they'll compress when you push on them. Now when you stick your needle under there, you can see the needle. If you stick it under the short face of the transducer, you're going to get, instead of getting just 2 parallel lines that are the vein, you're going to get a long thin line, which is the needle, and we direct that long thin line in between the 2 parallel lines, and we've acquired or stuck our target, in this case a vein. Now if we turn cross section, like I told you, we always start off, the vein looks like a circle. The needle is going to just look like a dot, and we direct that dot down into the center of the vein. Now again, remember, no matter how we're going to do this, we always start off cross section because we can identify our structure. We know the vein because it collapses easily, so there's 2 veins. The artery will collapse when you push hard enough. All right, let's talk about that cross-sectional approach first. It's called out of plane, but cross-sectional approach. This is the easiest to visualize in your head, but there's some mistakes you can make in it. So again, the vein is going to look like a circle. We press down with our transducer. Veins will collapse. We're looking for the needle to be a dot, and we're going to walk our needle right down to that vein. Now remember, if we don't move our transducer down the vein, we don't see where the needle is going. We see where the needle has been. And we really don't care about where the needle has been. We care about where the needle's going. In other words, we don't care about the needle shaft. We care about the needle tip. So we have to slide our transducer ahead of the needle so that we can see the needle pop into view. All right, again, we don't care where the needle has been. We care about where the needle's going. So we slide our transducer ahead of the needle will disappear. There's no needle underneath the beam of the transducer. And then we slide the needle into the beam. All of a sudden we can see it. And we know that's the needle tip because it's the front edge of the piece of metal. So here's what this would look like. We start by imaging our vein and compressing. We know that's our vein. We stick our needle underneath the transducer because we're starting very close, the needle very close to the transducer. The needle is going to appear at the very top of the screen. Then we're going to move our transducer. So here's the transducer. It's about to move. We're going to move our transducer, and the needle will disappear. The needle disappears because we're past the needle. Now we're going to stick our needle in a little bit further. We're going to advance our needle, and then the needle is going to appear in view. And when we see the needle appear in view, we stop moving the needle. Bam! Stop moving the needle. If we keep moving the needle, we're just going to see the needle shaft. So then we move the transducer again, and then the needle, boom. Now, you're real close to the vein, but go on and do it one more time. Move the transducer, the needle disappears, and advance the needle, and it's sticking right in the vein. That's how we want to do this. So it's transducer, second is the needle. Transducer, then needle. Transducer, then needle. Transducer, then needle. Here's what it looks like on the Phantom that we loaned you. So we start off, there's the needle at the top of the screen. We move the transducer till we can't see the needle. Then we slide our needle into view. Transducer, needle. Redirect if you need to. Transducer, needle, transducer, needle, transducer, needle. It's a stepwise approach. stepwise. It's a step at a time, going right down those CT scan slices until you got your needle in the direct middle of your vein. So Becky wanted me to remind you, you want to redirect. Now, when I'm doing vascular access, I don't think of the transducer as right and left. I think of it as right or wrong. So if I'm looking at my needle and I move my needle and it goes the wrong way, I move it the opposite way. So it's right, wrong, and not right, left. Some people's brains have a hard time with right and left. Mine is one of them. And so I try not to call it right, left. I try to call it right, wrong, or hot, cold, right? If you were playing that game, getting hotter, getting hotter, getting hotter, right? Think of it that way. You want to go into the right direction and then move your transducer and then move your needle into the plane of the beam. And you have to redirect as you get closer because it may have gotten out of plane again. Now, the problem people have with this is that they don't move their transducer. They just image the vessel and then put their needle in. Well, they get an image of the needle. It's just not the needle tip. So they start off right, and we've got the needle down the vein at the bottom, and the needle is all lined up. It's ready to go. But instead of advancing their transducer, they stick the needle in. So here we are. We're going to stick the needle in. Well, because we didn't move our transducer, the picture never changed. The needle still looks like it's at the top. But it's really not the top. It's advanced down into the tissue. Now, I don't recommend aspirating and stick a needle in something. I recommend you visualize your needle. But if you were aspirating, you might get into the vein and get a big flash of blood and know you're in the vein. But more than likely what will happen is your needle will keep on moving even though you got that flash of blood and you'll go through it. Now this I've seen happen many times. And most of the time when I hear a resident say, yeah, I got a flash of blood, but I went to feed my catheter or my wire and it wouldn't go. I must have been hitting a valve. You weren't hitting a valve. You were in the soft tissue behind the vein because you went through the vein and it won't feed through the soft tissues. Sometimes you'll get a good aspiration of blood and the carotid will be sitting back there and you get nice dark blood, but then you slip into the artery and then you forget, oh, I forgot to check again, and then you dilate the artery. And I saw that happen a few times a couple years ago. And then the patient gets a dissection. Remember, a dissection is a bad thing for a carotid artery because it causes strokes. That's a bad thing. So you don't want to do that. You want to make sure you know where your needle tip is. So the next video is going to be a fail video. This is, I get to record people doing things wrong. It's always fun. Maybe I'll get to see some things y'all do wrong sometimes, and I'll get to show it to you guys. No, I'm just joking. Just playing. I promise I'm playing. She's laughing at me. Can't get to see your faces. You're probably like, I don't want to participate now. But here's a resident of mine, and you can see that they are, can't get the pointer. Oh, there's the pointer. So you can see this is the internal jugular vein. This is the carotid. So they're not sticking the carotid because it's not behind the internal jugular vein. But you can see there's a lot of motion in the tissue. But the needle is not here. The needle is there. That's the needle shaft. The needle is somewhere back down here. And the reason why they can't see the needle tip is because they didn't advance their transducer down the internal jugular vein. And so they're seeing where the needle has been. I don't care where the needle's been. I care where the needle tip is. And so they are causing damage to this patient. They went through the back wall, and you can see that going through the back wall. And they're pulling their needle back into the plane that they're imaging. All right, so don't do that. There's the needle coming back. Now, the other way of doing this is that in-plane approach. The in-plane approach is not a good place to start, but I have to tell you about the in-plane approach so you can see how to do it. When I say it's not a good way to do it, it's not a good way for vascular access. It is a good thing to do if we're doing other procedures. So the in-plane approach, or where you look at the needle and long axis, we're going to use for paracentesis and thoracentesis. But for vascular access, you probably should start at least with the cross-sectional approach because it helps you know veins versus arteries. But once you stick the needle into there, it looks like a long, thin line. So it's easy to see where it was, where it is, and where it'll be going. Remember, we always start off in cross-section and we do the compression technique. You have to keep the vein on the screen the whole time to know that when you've turned long axis, you're still looking at the same vein. This is the hard thing to do. People slip off the vein and then they're not looking at it for a few seconds. And then they go parallel to the artery and they think they're looking at the vein. Remember, you can't do the compression technique in long axis because you don't know if you're compressing the vein and the vein is disappearing, or you're sliding off the vein artery and the artery is disappearing because you just are slipping off of it. So this is where people make mistakes with this. You don't have to worry about that when you're doing thoracentesis and paracentesis, those kind of procedures. So this is a good technique for other procedures, but I have to show you this procedure even with vascular access, okay? Because I'm going to show you how to use this to finish off your procedure in a minute. So this is how it would look. We would done the compression technique. We would rotate the long axis. Notice that the walls of the vein are bright. That means you're directly over the vein. The needle is very bright. That means you're directly over the needle. When the needle gets dull like that, it means it's going out of the plane of the beam and you have to redirect it back in. So like we talked about the last time, having to move hot, cold, right, left, right, wrong, same thing here. You have to move in and out of the plane of the beam. And when you're directly in the plane of the beam, the artery or the vein, whatever you're doing, has got bright walls and the needle will have a bright tip. That's how you know you're directly in the plane of the beam. Here's what it looks like on a human. So we're going to do the compression technique. That's the internal jugular vein. We're going to turn parallel, keeping it on the screen the whole time. And then we're going to stick our needle underneath the short face of the transducer. Not really. Here it is, though. And look what's back behind the internal jugular vein, the carotid. See, this is in long axis, and we brought it straight in. Now, when we're doing other procedures, we can just do the long axis. I mean, here's a paracentesis. You can see the needle. We're not worried about arteries and veins. We're just bringing our needle in. We want to see where it's going, where it is, and where it's going to be. Same thing. This is a peritonsillar abscess. We're using an endocavitary probe, and we're seeing the abscess, and we're watching our needle come in. Here's, sorry, the bar's in the way. I don't know how to get rid of it. There it is. Here's a abscess on somebody's leg. We can watch our needle come in there and make sure we're getting into the abscess. Same thing. So which technique is better? Well, for vascular access, I'd suggest you use a mix of both of them. So let me show you what that looks like. So we're going to start off transverse. We're going to identify our vein. We're going to do the compression technique. We stick our needle underneath the top of the bottom of the transducer as close as we can. We see the needle at the top of the screen. We're going to move our transducer up the vein, away from our needle. The needle is going to disappear because it's not in the plane of the beam anymore. Then we're going to advance our needle. The needle is going to appear lower down on the screen. Then we're going to advance our transducer again. Our needle is going to disappear. We advance our needle. The needle now is going to be closer to the vein. Once the needle is close enough to the vein, we know that it's pointing at the vein. We can take our transducer off of our arm or our leg or our neck, whatever we're doing, and we can turn it parallel now. And when we turn it parallel, we can see the needle pointing to the vein, and we advance the needle right into the vein. So see, you get the best of both worlds. Here's the way it is on that phantom. So we start off, we've got the needle right underneath the probe, so we see the needle at the top of the screen. We walk our transducer down, walk it down, probe, needle, probe, needle, probe. When we get close, we can take our transducer off. Excuse me. We can find the needle, so there's the needle, and then we advance our needle right into our vein, stop it before we get the back wall. So I hope that made some sense. You know, it's really hard to do this without seeing you guys and knowing you're getting what I'm saying, but when you practice this, and y'all can practice today or whenever your residency director say you have some time, you can practice this on the ultrasound transducer and phantom we gave you. It'll make a lot more sense. This is going to cadaver here. You can see why this mixed technique is really important, because here you're having a hard time visualizing the needle. So we're transverse. Here's the needle. We know that we're getting kind of close to the vessel, but it's hard to see the needle tip. So then we know we're close enough now, we can take our transducer and turn parallel, and we can go look for our needle tip, which is somewhere over here. We can go look for our needle tip and watch it then come right into the vein, right there. And we know we did the procedure correctly, even though our imaging was quite poor. So I hope that made a little sense. This is a little bit different technique. You're going to use this technique sometimes where your target is cross-section, but your needle is long axis. This is a really good technique if you're thinking about, like, if you're trying to hit an abscess that's deep in the tissue, or if you wanted to do a nerve block, you would want to get anesthetic around the nerve. If you were trying to hit this target, you would hit the target directly. You can see how you can image your needle very well in long axis. So this is still a kind of a mixed technique that we were just showing you. Here it is in nerve block. So we've got our nerves right here. They're in cross section, so they're running up and down the body. This is the neck. And here's our needle coming in long axis. And now we know we're not going to hit our nerve. We don't want to hit our nerve with our needle. So we come in and we can inject anesthetic around the nerve. Same technique if we want to do an abscess again. So here's our needle coming down into the abscess. We can see our whole needle, and we can make sure we're sitting in the middle of the abscess. We can watch it as we aspirate, so we make sure we get a good aspiration if we didn't want to incise it, right? Here's a joint injection. This is one bone, this is another bone, so this is the joint in between them. This bright line that connects the two bones is a joint capsule. And we can take our needle, we can see our needle coming down. So if we're going to do if we're going to put some steroids in this joint, we can see we're outside the joint capsule. That would not be an effective steroid injection. We'd want to come all the way down through the joint capsule. So this long axis, we're able to see that, and we can go on into the joint capsule and inject in there. If you're doing an aspiration, it's the same thing. All right. So we didn't talk a lot about thoracentesis or paracentesis. It's very much the same, but I wanted to show you the techniques for doing this. Any questions?